Horst, tell us what you're going to be doing today.
Yeah, I'm here with Collier, as you see, and we want to show you a new procedure which doesn't really belong to the field of structural interventions, but it belongs to the field of heart failure interventions. So I think it is of interest to this audience. Can we have the slides, please? It's a 47-year-old male patient. He's suffering from severe heart failure, systolic heart failure. He had a myocarditis in 2019. A CRT was implanted in 2020. EKG, left bundle branch block, TTE, LV diameter 65 millimeters, ejection fraction 30. There's mild mitral regurgitation and cardiac duplex is normal. So the procedure we're going to do here is the endovascular baroflex amplification, or EVBA. We do this with the Mobius implant. You may know that there is an electrical technique to do baroflex stimulation, but this is a mechanical technique where we implant a self-expanding rectangular nitinol implant. And this basically reshapes the carotid artery without expansion. And you can see this on the drawing on the right side. It kind of stretches the vessel wall, so it signals to the brain that the carotid bulb and the internal carotid artery is under high pressure, and that reduces sympathetic activity in the brain and increases parasympathetic activity. Next, please. This is effective in resistant hypertension. There had been, I think, 90 patients, 89 patients included in different trials, and you can see that this is a technique to reduce blood pressure long-term. 3-year follow-up showed 30 millimeters of mercury blood pressure reduction. Next slide. And now we are investigating this for the indication of systolic heart failure. These patients typically have heart failure class 3, and they are in need for treatment options beyond medical therapy and CRT, but not yet candidates for LVAD or heart transplantation. You can see on the right side the inclusion criteria for this procedure. Next slide. And this is the procedural planning for this specific patient here. You can see we do this based on CT, and you can see the measurements at the distal and common carotid artery, at the proximal internal carotid artery, and then 1 centimeter above. It's 8.5 by 7.9, 7.4 by 8.6, and 5.9 by 7.2. So I think now we should switch to Huub, and he can present the device before we start with the procedure.
Yeah, I will just show you special how we can prepare the system before the First, what we have to do is to flush the system. And we flush the system not in the distal part, but on the proximal part of the system with saline and heparin. Before we going flushing, we open the system halfway. We do that in the basin with saline and heparin. We put the needle filled with saline on the system, and we flush the system, and in the meantime we move it a little bit, but all air bubbles are going out. Done that, we close the system, and then it is ready for use. But I now will also show you how the system is working fully when it's expanded. You open the system halfway, then you can position it in the patient a few times. The next step, you go to the point of no return, we call that on this system, is on this actuator. And then we will fire the system. I have to do it like this. You see? And then he will release from the system.
And then we go in with our hands and grab it and release it from the delivery system.
And it should be done.
And once deployed, it's not retrievable? Not retrievable.
It's not when deployed, it's not retrievable.
It's not retrievable. I mean, it would be retrievable like when you try to an embolized stent to retrieve that one. But
sure.
That's basically, then you better should leave it there.
And you deploy it just
above... Are there
above...
any questions before we start?
You deploy it just above the bifurcation.
Well, can we go back to the last slide?
Yeah.
It depends upon the diameter of the proximal internal carotid artery and then a centimeter above. Last slide, please, again. And in this particular patient, we will have to place it half in the common and half in the internal carotid artery, because the internal carotid artery narrows down, let's say, a couple of millimeters above the bifurcation. Can we see the last slide again? Yeah, okay, here you see. So you see that the measurement at the takeoff of the internal carotid artery is 7.4 by 8.6, but then it narrows down to 5.9 by 7.2. So that means we have to implant it basically between the two outer yellow lines.
Horst, it's Howard.
Okay.
So just when you're planning to put this in, do you put it in only on one side? Do you choose that side ahead of time? Is it dependent on the arch anatomy, etc.?
Yeah, we implant it only on one side. We go for that side, which is more suitable according to the anatomy based on CT scan. And okay, one of the most important exclusion criteria is obviously any carotid plaque. So these arteries have to be really clean, otherwise we do not do this procedure. Any other questions before we start?
I think that's it for now.
Okay, so I have an 8 French sheath in the groin, and I will introduce 8 French guiding catheter, right coronary. Mal ein bisschen mehr Draht.
Mehr Draht?
Okay. Okay. Good. So the technique is very similar, obviously, to carotid stent implantation. This should be brachycephalic trunk.
Müssen wir einen Rückfluss haben?
Okay, let's go up. This is the common carotid. Okay. It's just de-air it. Okay, 5.5. Wait a second, it's not. Okay, go to 5.5. Yeah, little puff. More. Okay. Oh, I see a kinking distally. So let's go for an intracranial baseline angiography. Oops.
The flushing needle is on the table. The flushing needle, the small needle. This one. Nog on the table yet?
Jetzt ganz ruhig liegen, nicht bewegen. Ja?
5,5.
Okay. Ready? Okay. And now we go lateral, be careful. Es gibt immer mal so ein heißes Gefühl im Kopf, ne? Okay. Okay, now we go to the level of the carotid.
And why did you need that image of the cranial
It's for the
circulation?
study. I mean, it doesn't really make sense, but it's according to the study protocol. I mean, if you think about potential complications, why can I not move it here? Then obviously cerebral embolism could be a potential complication, so it's maybe good to have a baseline. That's something we also do for carotid stenting. Little puff. Okay.
Horst, Marcus, when do you give
here.
heparin in this case?
We did this after getting access to the groin. So now we can actually insert the wire. We're using an 014 Ironman wire. And there's the introducer, yeah. Okay. I will need a second plane also for the purpose of the study. Little bend. Can insert this in parallel to the 35 wire which I have in place.
So it's not over the wire, it's next to the wire.
It's a monorail technique.
Yep.
Like a carotid stent. Where I am. Little puff. Okay, let's park it there. There's a lot of kinking distally, but that's far distal of the place where we want to place the device, so it's not a problem. Let's zoom in. Maybe I can advance the guide a little bit more. Up to here. Another Cineron. Okay. This is not good for implantation. We go to the lateral view. Let's remove the Terumo wire. Okay, and this should be, can you go to 7.7? We need a little more contrast here. Okay. Okay, that's better now. Okay. Good. So now we need to prepare the device.
The water?
This water.
Yeah, in the sail, I opened it.
Uh-huh.
The sail.
Yeah. Okay. So we are flushing from the side hole.
Okay.
Should be fine, huh? Okay, good. Okay, we check the tip. That looks good. So we can insert it.
Ist wirklich?
Hm?
Das ist noch eine Kante, oder?
No. I think it's okay, huh? Okay. Can you froze the image and put it on the side?
Ja.
Okay. And keep this end here? Okay, good. Have it? Okay. Good. I go back a little bit with the guide.
Still 177?
Huh?
155?
Yeah, let me de-air it. I want to make sure that we did not introduce any air. Okay.
Kommt.
Now it's coming. Huh? There are always some air bubbles in, Same as with carotid stenting. When you introduce a catheter into the guiding catheter, then some air is sucked in. More and more is coming. Huh? Okay, and also here. Okay, good. We can give a little contrast. Okay, a little bit more distal, huh? Okay. Let's do an angiogram. Ready? Okay. What do you think? Now we are half in the internal, half in the bulb. Agree? More? More up? Okay. He's breathing, so that's a disadvantage, huh? Yeah. Shall we do another cine here? Okay, inject.
And we can open it and see.
We can start there and see
Yeah.
how it behaves, right?
Yeah.
Okay. So I turn this handle here and expose the distal part.
Make a scene, please.
Let's do another cine run. Position okay?
Yeah.
Okay, so we'll turn this around here and release the proximal part.
Detached? Yeah.
It's detached, yeah. Okay. And I can retrieve it now.
How long is the device? Is it around 2 centimeters?
That's 2 centimeters, right? Hoop?
Yeah,
Is it 2?
that's
Yeah.
it.
Okay. Now we are basically finished. We can do the angiogram. Ready? Inject. Yeah, perfect. It's actually sitting, the majority of the part is, device is sitting in the internal carotid, which is better.
Yeah.
And we expected that it will protrude into the carotid bulb because there's some narrowing at the upper edge of the device. Okay? Good. So now we do just the final angiogram in the other plane and then an intracranial run again according to the protocol. But the procedure is basically finished. And for those of you doing carotid stenting, I mean, carotid stenting is always a little bit of stress, but this is a stress-free procedure because these are healthy arteries, so there's no concern of any debris which may go intracranially. Are there any questions or comments?
Horst, quick question. Are there any acute hemodynamic changes that one has to monitor for during the deployment, like change in heart rate or blood pressure, anything like that from deployment?
No. I mean, it may be that you would be able to measure this, but it's not of clinical relevance. So for the implantation, obviously we measure blood pressure anyway, but there is no incident of hypotension, not acutely and also not during the long term in these heart failure patients. And also, as far as I know, in those patients with hypertension, the blood pressure reduction is not that dramatic that you have to be aware of any hypotonic situation, something like that. Okay.
So maybe this is
So
the
that's
question.
how we AP.
Maybe Howard can answer this question, or you. So the baroreceptors, where are the fibers located? Are they more in the internal, on the external carotid? Are they distributed over both? The carotid body itself sits at the bifurcation, right at the base of the bifurcation. So where are those? Where are the baroreceptor fibers that we're trying to affect with this device?
We're trying, I guess, you would try, so you have the internal carotid, and then you have sort of that pouching on the internal carotid, the carotid sinus. And there are receptors there, but I think, from other research that's been done from, whatchamacallit, the stimulator, that, they can find point places along where there are multiple places they can stimulate. So, especially in a healthy thing, I think it seems like pretty much anywhere you stimulate or stretch in that area, you get it. Right.
Any other questions or comments?
Yes.
I can barely hear you, Howard.
Yeah,
so
I would like just
the
to
sound
ask
is-
you whether you are happy with the position, mainly related to the degree of protrusion to the ostium of the external carotid artery, and then which is the degree of, let's say, malapposition that would accept in this aneurysmatic first part of the internal carotid artery.
No, we want to have as much of the device as possible in the internal carotid, but we expected here that this would not be possible because it's narrowing up at the upper edge of the device. So this is actually an optimal position. We even expected that it would slide down a little bit, which is still okay as long as, let's say, 50% of the device should be in the internal carotid.
Is this have any impact on the long-term treatment in terms of antiplatelet or anticoagulation in your experience?
We prescribe aspirin according to the protocol, and nothing else. I mean, after 6 months, it's healed in like a carotid stent, so then you can stop that.
Is this a one-size-fits-all, or are there different sizes?
No,
Three
there are
sizes?
different sizes, and I showed you the CT image of this particular patient. There are 3 different sizes, and they are chosen according to the diameter of the carotid artery.
Gotcha. So they're chosen to give some.
So if there's no acute effect on heart rate or blood pressure, how long does it take in the hypertensive patients? How long did it take to see the blood pressure effect? And in these patients, how do you measure? What is there any measure of effect, or you have to wait for the clinical results?
No, we are waiting for the clinical results. We had, by the way, really impressive effects in the study we performed in Georgia down there. And there was improvement regarding heart failure class, quality of life, BNP, ejection fraction. So really, throughout all parameters improved. So it's very impressive. I mean, this has to be confirmed by a randomized trial, of course, but according to the initial experience, that was really very impressive. In the hypertensive patients, it's like with all neuromodulation techniques, it's an effect which occurs over time. So it's not an immediate drop down, although some of the patients had that. But you see an increasing effect over time.
Right. Okay.
Any other questions or comments?
I have one question. Because I was engaged and I still do the neuromodulation, but usually in the parasympathetic nervous system. And it's a bit, frustrating if there is no clear endpoint. In this procedure, as we commented, the effect you can see in delayed time. And it would be very nice to have, some kind of endpoint of the procedure.
Technical success.
Yeah, technical success of the procedure. And for example, in terms of neurocardioablation, we developed some techniques to find the endpoint of the procedure. Is it maybe it is the advice or I don't know, comment that it may be some kind of stimulation of this region or something else would be beneficial to ensure in future that the procedure is successful and the device was deployed properly in the proper site?
Well, I mean, these are all good questions and well taken. I mean, with this procedure, there's there is the final decision when the device is implanted, we cannot retrieve it. So that means there's no way with this device to implant it, see, measure the results, and then decide whether we retrieve it or not. Because it can be retrieved only as long as less than 50% of the device are opened. And then I have to make the decision to implant it completely or not. So, I mean, we didn't do any acute measurements during the procedure. And this may be of scientific interest for the practical procedure. We cannot change anyway. So we have to make a decision to implant it and then wait for the results. Well, stimulation before, yeah, I mean, when we do the electrical barostimulation, we can test this. We put the electrode on different spaces there and test the effect, but also only basically in hypertensive patients. In heart failure patients, this is much more difficult because they don't have a blood pressure reduction, right?
Yep. Yep.
Does this answer your question?
Points well taken, yes. Yeah. So I guess this, in a lot of the neuromodulation field, we're looking for parameters that we know acutely tell us that we have a procedural success, but it's been a challenge in many of these cases. So, okay, thank you, Horst. We're just on time.
Thank you very much.
Thank you. Very interesting.